Hello, and welcome back to the VJHemOnc podcast. Since the approval of ibrutinib for follicular lymphoma in 2013, Bruton's tyrosine kinase inhibitors have become firmly integrated into the therapeutic landscape across several non-Hodgkin lymphoma subtypes. In today's episode, you'll hear some interviews from the 2025 ASH annual meeting, in which leading experts share updates and insights from a number of clinical trials exploring BTK inhibitors and BTK inhibitor-containing regimens in non-Hodgkin lymphoma. This podcast episode is part of a Spotlight On podcast series supported by AstraZeneca. This supporter has no influence over the production of the content. This podcast is intended for healthcare professionals only. To begin, you will hear about several BTK inhibitor trials in mantle cell lymphoma. First, Michael Wang shares the final update from the Bruin trial, outlining 4 to 5 year follow-up data of pirtobrutinib in relapsed refractory mantle cell lymphoma. Professor Wang then also presents an analysis of the ECHO trial, which examines time to third-line treatment after bendamustine rituximab, with or without acalabrutinib, in patients with previously untreated disease.
The Bruin study was presented quite a few years ago, and it was FDA approved. This time we have 4 to 5 year data. So basically, we've have longer data. So the main issue is, if how does the patient doing? Mainly in terms of toxicity. And did we have, with the prolonged treatment, do we have more side effects? First of all, the efficacy stayed relatively the same. The primary analysis was around 50, and this time is also around 50% response rate. And the CRs are also similar. But, there's only mild changes in toxicities. Atrial fibrillation during the 4 years of 50.9 months of follow-up time, there's only one more case of atrial fibrillation, which is reversible, was under control. And there was one more patient with the ventricular tachycardia that were also reversible. So we did not see the more toxicity events accumulate. So I really think that pirtobrutinib remained a very good drug with a durable response and should be continued to be used. So that was the accelerated approval and 5 year follow-up data. And and now the phase 3 study is in finishing enroll. The phase 3 is basically pirtobrutinib versus any BTK of choice. There's a randomized trial. I think that this trial most likely would be possible, especially in the toxicity area. That pirtobrutinib, in my opinion, is the least toxic BTK inhibitors we have. So not much new, but a prolonged efficacy, prolonged lack of toxicity. So I had 4 presentations, and I had another presentation on the ECHO clinical trial. The ECHO clinical trial reanalysis regarding the TTN2T, basically time to next treatment tool. So it's basically tell you whether concurrent therapy with acalabrutinib BR is better than BR followed by acalabrutinib. So in the community, our community doctors treating mantle cell lymphoma, they usually start BR, bendamustine rituximab with maintenance, and then if the patient relapsed, we give acalabrutinib. So when I presented the phase 3 trial, we are not using them separately. We're using them concurrently together. So bendamustine rituximab with acalabrutinib, we showed such a good result that not only US FDA, but also EMA from Europe proved this new combination therapy, triple therapy in the front line. So people continue to ask, well, Dr. Wang, that the possibility exists that the sequential therapy is not as bad as the first therapy, maybe superior. Why do I have to use the triple drug together? It is change our habit we already feel comfortable. It may add more toxicity. So in order to answer this question, we did this analysis, right? In conclusion, the TTNT2 basically if used concurrently therapy, the time to needing third-line therapy is much longer than the time for the sequential arm. In conclusion, is that according to our clinical trial post hoc analysis, these people on trial, they're not real world data, so we're relatively controlled population. 3 agents together is better than using 2 agents together followed by another agent. There are so many community physicians already adopted the FDA approval and using concurrent triple therapy without sequencing. That's the right way to do it.
Next, you will hear an update on the MAVO study from Austin Kim. This trial is investigating the AVO triplet combination in patients with relapsed refractory or treatment-naive mantle cell lymphoma.
In mantle cell lymphoma, the most common first-line treatments remains chemoimmunotherapy and a combination of targeted BTK inhibitors with chemoimmunotherapy. However, doublet and triplet chemotherapy-free combinations of a BTK inhibitor, BCL2 inhibitor, and anti-CD20 are challenging the current standard of care. So this MAVO study includes acalabrutinib, venetoclax, and obinutuzumab, and our hypothesis was that it would be safe and effective in both relapsed refractory and treatment-naive mantle cell lymphoma. And finally, we aim to study using minimal residual disease to help study time-limited therapy for discontinuing therapy with acalabrutinib and venetoclax. I'm excited to present the results on Sunday. So this was a phase 1/2 study looking at relapsed refractory and treatment-naive mantle cell lymphoma. So it was a 3-part study. First started in the very high-risk relapsed refractory mantle cell lymphoma. And if safety was confirmed, it would expand to the high-risk treatment-naive mantle cell lymphoma cohort, which included transplant ineligible and TP53 aberrant. And then if efficacy was met, there was a third cohort, which was low-risk treatment-naive mantle cell lymphoma. So the study started in the relapsed refractory setting and safety was met. So there was an 11-patient expansion cohort. So there were 20 patients that were enrolled in the relapsed refractory setting. And what we found was a complete remission rate was 75%. So then the study opened to 24 treatment-naive mantle cell lymphoma patients who were high risk. And what we found was that 17 of those patients had a high-risk TP53 mutation, which is associated with more difficult or aggressive disease. And what we found overall was the primary endpoint was met with a complete remission rate of 83%. And then within the 17 patients with a TP53 mutation, the 2-year progression-free survival was 82%, and overall survival was 94%. Also part of this study for the treatment-naive cohort was that patients who were in undetectable minimal residual disease after the 7 cycles of induction, acalabrutinib, venetoclax, and obinutuzumab were able to discontinue therapy if they remained in UMRD complete remission for 3 consecutive months. So we did find within this cohort that 15 of 19 patients were able to achieve UMRD complete remission and discontinue therapy. So that was 79% of patients. So far, only 1 patient has recurred after discontinuing therapy. And then finally going to cohort C, which is the low-risk treatment-naive mantle cell lymphoma cohort. As a primary endpoint for cohort B was met. We found 100% complete remission rate, and at a median follow-up of a year, 100% remained alive and without progression. And we also found that 8 of 9 patients were able to discontinue therapy after achieving minimal residual disease complete remission. So in summary, the AVO combination had high rates of complete remission in all 3 cohorts. It also had very high rates of undetectable MRD complete remission, allowing for many patients to discontinue acalabrutinib and venetoclax after only 10 cycles of therapy. I think what we did find for future study is that it does appear that patients who had highly proliferative or blastoid variant TP53 mutated mantle cell lymphoma, further investigation needs to be done in that specific population. But with these results, there is a 16-patient expansion cohort opening for the TP53 mutated treatment-naive cohort. And finally, I think this triplet chemotherapy-free regimen of AVO, or acalabrutinib, venetoclax, and obinutuzumab, warrants further investigation and randomized studies.
At ASH, we also had the pleasure of speaking with Tycel Phillips, who discussed a retrospective study investigating the outcomes and safety of 3 covalent BTK inhibitors for the treatment of mantle cell lymphoma.
In this sort of abstract, what we wanted to look at is just sort of outcomes and safety and toxicity with some of the covalent BTK inhibitors. As we know, globally, there are 3 covalent BTK inhibitors, acalabrutinib, zanubrutinib, and ibrutinib. Within the U.S., we only have 2 options, acalabrutinib and zanubrutinib, but ibrutinib was accessible for a long period of time. And so retrospectively, we look back just to sort of see outcomes in patient populations, time on treatment, progression-free survival, and to see if there was any sort of differences between the outcomes between these 3 by BTK inhibitors. Because in theory, they all are covalent BTK inhibitors, so we wouldn't really expect to see any efficacy differences. The more benefit for the second generation BTK inhibitors, acalabrutinib and zanubrutinib, has been a more of a toxicity profile, as you have less atrial fibrillation, less rash, less infection risk. So from our abstract, what we can see, which again, with the caveat is it is a retrospective study, so it is a limited snapshot and it is subjective to the information available in the records. It does appear that the 2 second generation BTK inhibitors probably have some beneficial progression-free survival and sort of time to next treatment benefits over ibrutinib. A lot of this, I would speculate, is just related to the toxicity profile of ibrutinib, because the patients ideally are not able to stay on the drug as long as they are the other second generation BTK inhibitors. When you look at a comparison between acalabrutinib and zanubrutinib, there was no statistical difference between these 2 molecules, which would be expected in this situation, given that the molecules themselves both have very comparable safety profiles. Now, just to be clear, most of the patients had ibrutinib because it was extracted from an older data set. Next, the highest percentage of patients had acalabrutinib, and zanubrutinib, because this is recent approval, had a much smaller pie of the patients utilizing this medication. So again, you do have some inequity as far as utilization of these medications, which could probably contribute to some of the results. But all in all, it fits with the suspicion that, again, the second generation BTK inhibitors is what we're seeing in clinical practice, much more tolerable than ibrutinib, and again, will likely be better for the patients because, again, less dose reduction, less dose stoppages, and probably keeping the patients on these medications longer, because unfortunately in mantle cell lymphoma, we still have a dearth of outcomes and a dearth of options and dismal outcomes in the post-BTK setting. So that will invariably affect long-term outcomes if you cannot keep these patients on this medication.
We will now move to trial updates in Waldenström's macroglobulinemia, starting with the long-term follow-up of the Waldenström's cohort from the Bruin trial, presented by Cheah.
Bruin was a very large phase 1b/2 trial evaluating the non-covalent BTK inhibitor pirtobrutinib in a range of different B-cell malignancies. At this meeting, I'm updating the results for the 80 patients with Waldenström macroglobulinemia that were treated with pirtobrutinib. This was a mixture of patients treated on both phase 1b and phase 2, although the majority of patients received the recommended phase 2 dose of 200 milligrams. 63 patients were BTK exposed and 17 patients were BTK naive. But although we've presented the overall results previously in terms of the response rates, we present updated follow-up median of 33 months and pretty encouraging long-term PFS rates and duration of response in patients treated with pirtobrutinib, irrespective of exposure to prior BTK inhibitors. This is important because patients with experiencing disease progression after covalent BTK inhibitors actually have very few approved therapies, and the activity and safety of pirtobrutinib in this setting is very encouraging.
Next, Jorge Castillo will discuss the results of a phase 2 trial of pirtobrutinib plus venetoclax in previously treated Waldenströms, before sharing the final report of a phase 2 study of ibrutinib and venetoclax in treatment-naive patients.
So this year at ASH 2025, we had an oral presentation, and we talked about a phase 2 study combining a non-covalent BTK inhibitor called pirtobrutinib with a BCL2 inhibitor called venetoclax. The idea behind this study is to provide patients with Waldenström's macroglobulinemia with a treatment that is non-chemotherapy, fixed duration, all oral. So pirtobrutinib starts 200 milligrams daily, and we do that for about 4 weeks. And then we continue pirtobrutinib, but we add during the second month venetoclax. This is a BCL2 inhibitor. And we started about 100 milligrams daily for a week, then 200 milligrams daily for another week, and then 400 milligrams daily for 2 additional weeks. That's cycle 2. And starting on cycle 3, we basically give full doses or standard doses of pirtobrutinib 200 and venetoclax 400 once a day for the duration of the study, which is a total of 24 cycles for a week each cycle. And once we reach that point, we stop therapy. So what I presented was the initial experience on 27 patients who have completed at least 6 months on study. And the reason we chose that point is because based on the assumptions of our study, in which we wanted to induce a very good partial response of 35% or better versus a 15% or lower, that would be our undesirable level, we needed about 42 patients. And for that, we needed to have at least 12 participants attaining a very good partial response or better. So when we did the analysis at that moment on the first 27 patients, we actually got 15 patients who got into a very good partial response and complete response. And therefore, the study met in endpoints. And I think that made it so interesting that the ASH decided that it was worthy of an oral presentation. So our patients were patients who had at least one line of therapy for their Waldenström. So this is for patients with relapsed disease. And the range was between 1 and 4, but the median was 1. And some patients had already been exposed to covalent BTK inhibitors, about half of the patients. And most patients have gotten exposed to rituximab and chemotherapy, as we do normally in these type of patients. I would say 40% of patients were women, and all the patients have mutations in MYD88. There was about 40% of patients got CXCR4 mutations and about 20% of patients with TP53 mutations. TP53 are really interesting for us because there's emerging data showing that those patients tend to have worse outcomes with any treatment. So that was an important aspect of what we did. So when we analyzed our data, we not only were able to see that 15 patients got into a very good partial response, but we also saw that 3 patients got into a complete response. Now, complete responses is something that we are very interested in, specifically when we compare outcomes of patients with other conditions like chronic lymphocytic leukemia or multiple myeloma. We do obtain very high rates of very good partial response on those patients, to the point that we're talking about minimal residual disease and things of this nature. Those concepts are foreign to Waldenström's because we don't get to complete responses to begin with. So the fact that 3 out of the 27 patients attain a complete response with the first 6 months of therapy, then I think that really is very interesting for us. So hoping that we can induce deeper responses, typically deeper responses translate to longer responses. And that's the idea behind it. So the accrual of this study continues. We have 1 more patient to go before we can complete the accrual of this study. And I'm really looking forward to actually show the data from the complete group sometime in the near future. I think I can safely say that the combination of pirtobrutinib and venetoclax induces fast and deep responses in patients with relapse disease and with Waldenström's disease. The second important part is going to be how durable this response is going to be once we stop therapy. So I think it's an innovative regimen. And if everything goes well, I think this is going to become a new treatment option for patients with Waldenström. We also presented a poster with study in which we combined the covalent BTK inhibitor called ibrutinib with a BCL2 inhibitor called venetoclax. In this study, we tried to induce a combination of therapies that will elicit a fast and deep effect, and hopefully providing patients with a non-chemotherapy regimen that is finite. This study ran into some trouble because we had already accrued 45 patients out of the 50 that we were initially planned to accrue. And 2 patients experienced a grade 5 arrhythmia, which means they died from this arrhythmia. And the etiology of the arrhythmia is unclear. We were not able to do autopsies on these patients to understand exactly what the problem with the arrhythmia and what exactly happened there. So we don't know very well the etiology of what that happened. But the best thing to do at the moment was to stop study therapy. So fortunately or unfortunately, some patients completed almost the 2 years of therapy. Some patients did not. And the median duration of treatment in the group was about 10 months. But everybody stopped at the same time. So we continued the study follow-up. Even though the study therapy was stopped, we continued the follow-up. And so what I presented at ASH this year as a poster is the final analysis of this study. So in this study, what we did see was that after therapy was stopped, counting from the moment in which therapy started, there was a median time to progression of 3 years. And in my mind, that means that out of those 3 years, 10 months were spent on therapy, and then about 2 years were spent off therapy, which leads me to believe that the combination can induce durable responses. And based on that, that really informs the need of additional trials. So we have another study in which we are combining now pirtobrutinib, which I believe is a safer agent with venetoclax, also for 2 years. And that was an oral presentation at ASH this year as well. So I think the combination of BTK inhibitors and BCL2 inhibitors, I think they do provide some synergistic approach to patients with Waldenström's. And that, to me, is of important value because these treatments typically are given as monotherapy in an indefinite manner. So if we can treat patients with finite treatments that will allow them to be off therapy for quite some time, and then maybe get retreated again with these agents in the future because they were not exposed to these treatments long enough to become resistant. So I think there is value to that specific approach. Obviously, more research is necessary to understand if that is something that we can do.
For the final 2 updates, Lorenzo Falchi will share the first results of the MYTHIC-FL2 trial, combining zanubrutinib with mosunetuzumab in patients with newly diagnosed high-burden follicular lymphoma. And Jason Westin will provide an update on the SMART-STOP trial, evaluating a 4-drug regimen containing the BTK inhibitor acalabrutinib in newly diagnosed DLBCL.
Here at ASH, we're also presenting the first early look at our MYTHIC-FL2 trial program. This is a series of academic trials we're putting together for patients with newly diagnosed high-burden follicular lymphoma. In years past, we presented the results of MYTHIC-FL1 study, testing mosunetuzumab as a single-agent, subcutaneously administered drug for patients with high-burden follicular lymphoma. And we really observed very encouraging results with high response rates and a good duration of response with the available follow-up. In MYTHIC-FL2, we're trying to test whether the addition of an oral agent, an oral BTK inhibitor, zanubrutinib, could improve these results. And the rationale for that is that we're seeing that after administration of mosunetuzumab in patients in the MYTHIC-FL1 study, we see an expansion of CD8 positive T cells that may start exhibiting some signs of exhaustion. And we saw an opportunity to potentially mitigate or reverse that exhaustion as a means to improving clinical results. So in this trial, we added zanubrutinib given orally continuously at 320 milligrams daily for a total of 12 months. And then the rest of the study remains similar to MYTHIC-FL1 with mosunetuzumab given on a step-up dosing schedule in cycle 1 and then every 3 weeks for 8 cycles, which is roughly 6 months. Patients in a complete response would only continue on the zanubrutinib. Those with a partial response continue both drugs. And obviously patients with less than that response will be taken off study because they wouldn't benefit from the program. We enrolled so far 54 patients. 51 were evaluable for efficacy. Most patients are still on treatment, so the follow-up is short, 6.5 months. But we saw very good deliverability of the treatment. Very few cycles were delayed. No patient really interrupted treatment permanently or discontinued treatment permanently. So the safety and the deliverability of the treatment is really good. And we started to see an early good efficacy signal. 92% of the patients had an objective response. 82% of the patients had a complete metabolic response. Obviously, we can't speak about durability. As I mentioned, the follow-up is short. On the safety side, we certainly didn't see any safety signals. The CRS profile or cytokine release syndrome profile was quite consistent with a single agent study. Other adverse events of special interest, neurotoxicity, injection site reactions, skin manifestations on the mosunetuzumab side, or bruising or bleeding or atrial fibrillation on the zanubrutinib side were really consistent with the safety profile of each individual single agent. So again, an early look of very promising early results for this combination.
At the 2025 meeting, we presented the primary analysis of the SMART-STOP trial. This is a trial that we did at MD Anderson as a follow-on to a study we previously did called the SMART-START trial. Both of these trials are evaluating the potential of novel combinations in patients with newly diagnosed diffuse large B-cell lymphoma. For nearly 50 years, CHOP has been the backbone of chemotherapy, and all new target agents have been added to CHOP. but we've explored the possibility of adding a targeted agent to a targeted agent. And in the SMART STOP clinical trial, we did a 4-drug combination, lenalidomide, tafasitamab, rituximab, and acalabrutinib. We call it ULTRA. And patients get 4 cycles of that treatment. If they have a CR, they would get less or no chemotherapy for newly diagnosed large cell lymphoma. In the analysis we presented at this meeting, we had a 57% complete response rate and excellent outcomes, more than 90% overall survival, 98% overall survival at 2 years, 86% progression-free survival. But what's really important is that the patients who received less or no chemotherapy did very well. And the few patients who had a progression of their disease after having no chemo were able to get a CR to go ahead and get chemo. The patients who had less than a CR to the lead-in got a CR to chemo, which basically means we can now conclude that the targeted therapy upfront, the SMART clinical trials, do not compromise curative intent and are a vehicle for us to explore ways to improve outcomes in large B-cell lymphoma.
Thank you for tuning in to this episode of the podcast to hear some of the latest updates on BTK inhibitor clinical trials in non-Hodgkin lymphoma. To explore more of our content from the ASH 2025 meeting, make sure to visit VJHemOnc.com. Don't forget to follow us on X at VJHemOnc to stay in the loop, and subscribe to our podcast on Spotify, Apple, or Podbean so you never miss a new episode. Until next time.